death, breath, life, family, heaven. Many thoughts kept crossing on my mind. Strong chloroform smell invaded my nostrils. All these alarms and peeping. Am I dead? Desperately, I tried to open my eyes. I was surrounded by white coats and walls and bright lights. The fear that ran through my veins in this place is so familiar. Where am I? You know, let me tell you my story. I am a second-year RT student, and 6 months ago I got into a tragic car accident. It was just few seconds until ambulance came and took me to the hospital. I couldn't move. I felt my ribs were broken. Even breathing was painful. With heavy, labored breathing, I lost my consciousness. I never knew what happened after. I woke up confused, and everything seemed like a vivid dream. Here, the healthcare providers tried their best to support my recovery. Finally, after several weeks, I left the hospital.
What we have just seen is one of the real-life situations that the healthcare providers usually face in hospitals. Emergency department is full of cases that requires immediate intervention, such as cardiac arrest or trauma. As a respiratory therapist, your role is to keep an eye on airway management to ensure that the patient gets adequate oxygenation and ventilation. Inability to protect airway or failure to secure an adequate airway can quickly lead to death or disability. Consequently, intubation with subsequent mechanical ventilation is a common life-saving method. The core benefit of mechanical ventilation includes the improved gas exchange and decreased work of breathing. Over the years, mechanical ventilation was representing a fundamental form of life support in critically ill patients. From the past until today, there is continual development to increase the patient quality of life as well as the ventilator capabilities to be more intelligent. This video aims to provide the historical perspective around the beginnings of the ventilators and the background of the changes and challenges in the past on its clinical application.
The story starts in the 2nd century, when a Greek physician called Galen introduced the idea of mechanical ventilation. He described his concept simply as follows. If you take a dead animal and blow air through its larynx through a reed, you will fill its bronchi and watch its lung attain the greatest distension. Over 1300 years passed since Galen presented his idea, and no one applied it. In addition to that, no one could understand ventilation. However, a light of hope has glowed in the mid-16th century when Andreas Vesalius, the great anatomist, demonstrated the power of mechanical ventilation using a fireplace bellows to artificially ventilate a dog through the trachea while opening an animal chest. Accordingly, the Royal Human Society of UK called for development of the resuscitation equipment and offered prizes and medals for the work in this area. Since then, in 1776, John Hunter developed a double bellow system which placed ambient air in and removed air out of a dog's lungs through the tubes in the trachea. Also, one of the most important contributions to enhance the use of positive pressure ventilation was in 1780, when Francois Chausier devised a simple bag and face mask for artificial ventilation.
As you know, any development comes with struggle and challenges. Thus, while ventilation using bags and bellows were widely used in America and Europe, concerns were being raised about their effectiveness. Well, that's medicine. It's a science about uncertainty and probability.
Consequently, a critical report appeared in 1827-1828 in France showing that bellows ventilation can cause fatal lung damage due to high inflation pressure and primitive airway security. Therefore, the Royal Human Society of UK and the French Academy abandoned the use of bellows ventilation. Thus, it was discouraged from medical practice in the mid-1800s.
Because of what happened, scientists were looking for an alternative solution that can replace the positive pressure ventilation. Let's try to think the way they did. What could be better than positive pressure ventilation? Would it be better if we used a principle that can mimic the normal way of breathing?
A new chapter of history began when the concept of negative ventilation appeared. John Dale, Alfred Jones, and Dr. Wallace, all of them are considered pioneers in introducing the negative ventilation to the medical field. How? In 1832, John Dale produced the first tank ventilator. It was an airtight box with the patient sitting inside it. Negative pressure was created manually by pumping air into and out of the box. In 1864, Alfred Jones patented for the first tank ventilator in America, even though his design was similar to John Dale's machine. Later, in 1876, Dr. Wallace presented a new version of the tank ventilator. In this new version, a bar is placed on the patient's sternum to measure tidal exertion, and air was evacuated from the cylinder by bellows. Unfortunately, this device seemed to have been used only for resuscitating the apparently drowned pupil and with little success. Over the next 50 years, many other ingenious devices were invented for negative pressure ventilation. However, their practicality for severely ill patients was limited. Therefore, a few of them had been used.
Despite that, negative ventilation became reality after Drinker and Cho designed the iron lung in 1928. To clarify this point, I would like to know, did you hear about the polymyelitis or poly disease?
During the period from 1930s to 1960s, poly epidemics had spread across Europe and America. Poly disease is a highly contagious viral infection that can lead to paralysis, breathing problems, or even death, and iron lung was used to manage poly patients. Iron lung works by controlling the pressure within the chamber using air blowers. Also, you can notice that it had a similar design to the tank ventilator built by Dr. Wallace. Even though Drinker's iron lung was the first negative pressure ventilator to be used successfully and widely in clinical practice. Iron lung helped to save many lives, but it was heavy and difficult to use. Therefore, in 1931, a severe polymyelitis epidemic prompted Emerson to build a simplified tank respirator. Because of its low cost and ease of operation compared with the iron lung, Emerson tank respirator became the mainstay in treating patients with respiratory paralysis. The use of negative pressure ventilation reached its peak during poly epidemics, and it was common to see several tank ventilators in the ICUs.
Now what about the positive pressure ventilation? Do you expect it to be completely abandoned? Actually, during the period from mid-1800s to mid-1900s, it was widely used in physiology laboratories and for some clinical cases when the iron lung is not indicated or inconvenient.
In 1888, other concern has appeared. The healthcare team at the New York Foundation Hospital were concerned with the high mortality rate in patients with crop and laryngeal diphtheria. Such conditions can block the airway and must be restored by inserting a tube or tracheostomy. So a physician called Joseph O'Dwyer developed a foot-operated bellows that could be connected by rubber tubing to the endotracheal tube. O'Dwyer proved to be the most persistent advocate of intralaryngeal tubes for managing upper airway obstruction.
After this, many other positive pressure ventilation instruments started to appear in the market in early 1900s.
In 1905, Rudolf Brauer invented helmet-like device which provides positive pressure ventilation to the patient's head in sealed chamber using Rudolf Brauer invention, two American surgeons, Janeway and Green, developed the rhythmic inflation apparatus in 1909. This device had a valve that produces rhythmic fluctuations in pressure and controls respiratory frequency and inspiratory to expiratory ratio. Also, a pulmonary resuscitator has been invented by Heinrich Draeger in 1907, and it has been developed with years to include oxygen cylinder and to be controlled by the movement of rotating handle. It was commonly used for emergency cases in mines and fires.
Now, this is the important part that will lead us to a conclusion. With the increase of the interest in positive pressure ventilation, do you think that the use of negative pressure ventilation continued? We know that polio epidemics had spread from 1930s to 1960s. Also, we know that tank respirator was used in treating polio patients with respiratory paralysis till 1950s.
Despite the use of negative ventilation, in 1946, death from polio in Los Angeles reached 80%. Consequently, Mr. Ray Bennett developed an intermittent valve that was originally designed during World War II. In this valve, positive pressure can be applied only during inspiration, allowing for passive expiration. Ray Bennett then produced a breathing device that incorporated the intermittent valve.
What was the benefit?
In 1948, during polio epidemics, positive pressure ventilation administered with Mr. Bennett's equipment saved lives of a significant number of patients for whom the negative pressure ventilators alone were insufficient. That decreased the death rate in Los Angeles to 17%.
At the same time, when polio struck Copenhagen, Denmark in 1952, the mortality rate for patients on iron lung reached 87%. So, what did they do? How did they face that major crisis?
Dr. Henry Lassen, chief physician at Blegdam Hospital in Copenhagen, was shocked by the rising death rate. He admitted, "Although we thought we knew something about the management of bulbar and respiratory poliomyelitis, it soon became clear that only very little of what we did know at the beginning of the epidemic was really worth knowing." Lassen knew he had to do something. He was advised to consult Epson, an anesthetist trained in Boston, USA. A meeting was done on Monday, August 25, 1952, at the Blegdam Hospital between Lassen, Epson, Paul Astrup, and other staff members. Dr. Epson concluded that inadequate ventilation was the cause of death, so he suggested to do tracheostomy with positive pressure ventilation. Further, he cited the recent experiences in the US of using the intermittent valve to provide positive pressure breathing to polio patients. Dr. Lassen was not convinced by Epson's arguments. He was skeptical, but the situation was dire enough for him to give Epson a chance. Dr. Epson started the trial on a 12-year-old girl. An ENT surgeon performed the tracheostomy and Epson succeeded to save her life. During the remainder of the epidemic, about 1,500 medical, dentistry, and nursing students worked around the clock to provide bag ventilation for polio patients. By mid-1900s, it became evident that negative pressure ventilation may not be the good choice to ventilate patients with respiratory failure. And these are some of the mentioned reasons. The high mortality during polio epidemics despite the use of iron lungs, largeness of the size of the iron lung, the issue of the access to patients, and the difficulty of maintaining effective ventilation while using the iron lung. Also, negative pressure ventilation was not suitable for apneic patients or patients under heavy anesthesia. In fact, many reports appeared in 1936-1938 describing remarkable outcomes with using positive pressure ventilation for treatment of pulmonary edema. Let us recap. The history of mechanical ventilation started with positive pressure ventilation, then it was abandoned. So, the use type changed to negative pressure ventilation. However, Once again, positive pressure ventilation started to gain popularity in providing ventilation. And in the next 50 years, great developments have been achieved in mechanical ventilation. Dr. Robert Kaczmarek from Harvard University described the development of ICU mechanical ventilators during the second half of the 20th century into 4 generations. The first generation of ventilators. The first generation of ventilators was between 1940s and 1960s. This generation of mechanical ventilation has limited features. Only volume-controlled ventilation, the inability of the patient to trigger the ventilator, and there was no PEEP. Examples of ventilators of this generation include Mork, Emerson, and external ventilators. External ventilator was a bit advanced compared to Mork and Emerson. It had a double circuit, it could monitor air pressure and tidal volume, and it has an accurate setting of respiratory rate. The second generation of ventilators appeared in the mid-1970s to early 1980s. This generation was similar to the previous one because it had only volume ventilation and simple monitor for tidal volume and respiratory rate. But there were new features include patient triggering capability and basic alarms for high pressure, high rate, and low tidal volume. Further, intermittent mandatory ventilation and pressure support modes of ventilation were introduced during this period, in addition to pressure control as a type of breath control. Examples of ventilators of this generation include MA1, Siemens Servo 900, and OYO 560.
You can see the gradual awareness about the power of mechanical ventilation. Each time, the companies try to provide more advantages. In the third and fourth generation, we will see more progression.
The third generation of mechanical ventilators appeared in the early 1980s to the late 1990s. The ventilators during this time became more sophisticated. One of the important features was using computer microprocessor to control breath delivery. Other features included flow triggering, adding extensive alarms and monitors, and waveforms that represent pressure, flow, and volume. The available modes include SIMV with pressure control and pressure support, and the new mode is APRV. Examples of ventilators from this generation include Puritan Bennett 7200, B1000, and Servo 300. The fourth generation of mechanical ventilators appeared in the late 1990s, and they are still developing until the present time. These ventilators are characterized by complexity and versatility. One of the special features of this generation is using the closed-loop control. Also, there are some ventilators that are used for additional purposes, such as transport ventilators, home ventilators, and non-invasive ventilators. The available modes of this generation are ASV, Smart Care, and PAV. Examples of ventilators from this generation include Puritan Bennett 840, Avia, Servo I, and Draeger Evita XL. Over the past years, there was a mystery that surrounded pupil death. the spread of epidemics that have a high risk of mortality with unknown cause and unknown treatment. In that time, fighting to live was very painful and it followed severe complications. But now, the existence of mechanical ventilation gives us the opportunity to save people's life and pull them from the edge of the danger to the zones of safety. After all, the story of mechanical ventilation doesn't end yet. The development continues and more intelligent devices are manufacturing.